1, 2,
And review 70-year-old female
Oh shit, I almost got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's start of
300 please.
I'll keep you on again.
Pulse check. No pulse.
no more pulse.
Yeah. Here, what do the ECMO people say? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
Oh. Oh.
You know, usually when we talk about a medical diagnosis, there's this expectation of mechanical precision, right?
Absolutely. Like you want a clear answer.
Yeah. Like you break your arm, the x-ray shows that jagged white line, and the doctor just points to the screen and says, there it is, you know?
Yeah.
Broken or not broken, it's clean, it's visible.
Right. We really crave that visibility in medicine. We want to look at a monitor, read a number, and just have it give us a simple, undeniable answer.
Exactly.
We basically want the body to act like a machine we can just plug a diagnostic tool into.
But then you step into the world of physiological labor, you step into obstetric nursing, and suddenly that x-ray machine is just completely useless.
Completely.
We're looking at a diagnostic landscape that is incredibly murky. I mean, you are trying to assess two entirely different patients at the exact same time, the mother and the fetus.
Yeah, and one of them is locked inside a fluid-filled vault where you literally can't even see them.
Right. It is the absolute definition of diagnostic muddy waters. And that complexity is exactly why we are dedicating this time to physiological labor and nursing management.
Yeah, we're taking a mountain of clinical guidelines, pathophysiology textbooks, and evidence-based nursing practices, and we are just distilling it all down for you.
Exactly. Consider us your clinical mentors for this deep dive.
Yeah.
Our mission right now is to aggressively apply the Pareto principle.
Right, the whole 80-20 rule.
Yes. We are sifting through the noise to extract the 20% of obstetric concepts that are going to yield 80% of the value for you.
And by value, we mean what is actually going to show up on your nursing exams.
Yep.
What will trick you on the NCLEX, and, most importantly, what is going to inform your real-world clinical judgment when you are actually standing at the bedside.
Right, because we are focusing relentlessly on safety, maternal safety, fetal safety, prioritization, and, well, spotting those classic clinical traps.
Oh, those traps are everywhere. They're designed to test if you truly understand the underlying physiology, or if you just memorized a list of textbook facts.
Which, spoiler alert, memorization will totally fail you in an emergency.
It really will. Understanding the why and the how is what will actually save your patient.
So, we're talking directly to you, the future nurse whose critical thinking is quite literally going to dictate whether a mother and baby go home safely.
You need to know what matters, why it matters, and the exact sequence of actions to take when things go wrong.
But before we can jump into the high adrenaline emergencies like cord prolapses and fetal decelerations, we kind of have to understand what actually gets the baby out in the first place.
Yeah, we have to unpack the foundational mechanics of labor.
So we hear this phrase, the 5 Ps, all the time in nursing school: passenger, passage, powers, position, and psyche.
It sounds a bit like a corporate synergy seminar, doesn't it?
It totally does.
Right.
Like, let's circle back on the 5 Ps, but let's break down what this actually means at the bedside, starting with the passenger.
Right, that's the fetus.
But it's not just about the baby existing, is it? It's about their geometric relationship to the mother's pelvis.
Exactly. The passenger is a dynamic participant. When we evaluate the fetus as the passenger, we are assessing 4 specific anatomical relationships.
Okay, what are they?
Presentation, position, lie, and attitude. Let's start with presentation.
Okay.
This simply means what anatomical part of the fetus is entering the pelvic inlet first. In a safe, uncomplicated labor, this is cephalic, head first.
But if I'm doing a sterile vaginal exam, I can't actually see the head. I'm just feeling around in the dark.
Right.
How do I actually know it's a head and not, say, a buttock?
Well, you are feeling for specific skeletal landmarks. The fetal skull isn't a solid cue ball, right?
Yeah.
It's made of membranous spaces called fontanelles and intersecting lines called sutures.
Ah, right.
So when you sweep your fingers over the presenting part, a cephalic presentation will feel hard and round, and you will physically trace those suture lines.
And if it's not the head.
If it's a breech presentation, you are going to feel the soft, smooth, irregular tissue of the buttocks. You might even feel the cleft. left.
Oh, wow. Okay.
Or in a compound presentation, you might feel a hand slipping down alongside the head.
Okay, so presentation is the body part.
Yeah.
Got it. Then there's the fetal lie. This is the relationship of the fetal spine to the maternal spine.
Yeah, think of it as an axis. A longitudinal lie means the spines are parallel.
Like they're lined up?
Exactly. The mother's spine and the baby's spine are lined up in the same vertical direction. The baby could be head down or the baby could be breech, but the axis is parallel.
Okay.
A transverse lie, on the other hand, means the baby is horizontal. The fetal spine is perpendicular to the mother's spine.
And obviously a baby cannot be delivered vaginally if they're lying sideways across the pelvis. I mean, the math just doesn't work.
It physically does not work.
But here is where it gets really interesting and where I think exams love to trap students.
Mm-hmm.
Fetal attitude.
Oh, yes. The
Exactly.
attitude.
When I hear attitude, I instantly picture a teenager rolling their eyes and slamming a door.
Yeah.
In obstetrics, what physically is fetal attitude?
Fetal attitude refers to the relation of the fetal body parts to one another. Specifically, we are talking about the degree of flexion or extension of the fetal head and neck along the spine.
Okay, so how tucked the chin is.
Yes. The expected ideal attitude is complete tight flexion. The baby's chin is tucked firmly against their own chest, their arms are crossed over their thorax, and their knees are drawn up to their abdomen.
Why is that chin tuck so critical, though? Like, what does that do mechanically?
It changes the diameter of the skull that has to fit through the bone of the maternal pelvis.
Okay.
When the chin is tucked, the baby is in a vertex presentation. This presents the suboccipito-brygmatic diameter of the skull.
It's a mouthful.
It is, but it basically means the absolute smallest possible circumference is presented to the pelvic inlet. It acts like a perfect wedge.
I assume the concerning finding here is the opposite of flexion, right? Extension.
It is highly concerning. If the fetal neck is extended, the baby is essentially looking straight up. This is effaced presentation.
Yikes.
Yeah. Try tilting your head all the way back and imagine trying to push the front of your neck and your chin through a tight ring.
No, thank you.
Right. You are no longer presenting that narrow top of the head. You are presenting a much wider, awkward, elongated diameter.
And from a nursing perspective, if a patient has a fetus with an attitude of extension, what is the actual clinical consequence?
It makes it incredibly difficult and often physically impossible for the head to maneuver through the ischial spines of the maternal pelvis.
Because it's too wide.
Exactly. The bony structures will just grind to a halt. This results in a prolonged, exhausted labor, a complete failure to progress, and ultimately the need for a cesarean birth to save both patients.
Okay, so the passenger has to be tightly flexed and head down, but they also have to fit through the passage. That's the maternal pelvis and the surrounding soft tissues of the pelvic floor.
Yes, the second P.
I read that primiparous clients, like those having their first baby, often have a much harder time with this specific P compared to multiparous clients.
They absolutely do. The maternal pelvis is not just rigid bone, you know. It's heavily reliant on the ligaments and the soft tissues of the cervix and vagina.
Right.
In a primiparous patient, those soft tissues have never been stretched to this extreme capacity before. They are taut.
So they fight back.
Yeah, they provide intense resistance against the descending fetal head, which can really slow down the internal rotation the baby has to do to fit through the pelvic outlet. In someone who has had 3 babies, those tissues are much more yielding.
Which makes the next 2 Ps even more vital to overcome that resistance, right?
Yeah.
Powers and position.
Yes.
Powers refer to the maternal efforts. We have the primary powers, which are the involuntary uterine contractions, and the secondary powers, which are the voluntary pushing efforts of the mother.
It's crucial to understand the mechanism of those primary powers, though. Contractions do not just squeeze the baby downward.
Wait, really? I think most people picture it just like squeezing a tube of toothpaste.
It's a common misconception. The muscle fibers of the upper uterus actually shorten and thicken with every contraction. They physically pull the lower uterine segment and the cervix upward over the baby's head.
Oh, like pulling a turtleneck sweater over a head.
That is the perfect analogy. That mechanical pulling is what actually causes the cervix to dilate and efface.
In a maternal position, the 4th P can either help or completely sabotage those powers. Like if a patient is lying flat on her back in a hospital bed, she is basically fighting gravity.
Completely fighting it. The positioning of the client during labor is a direct, actionable nursing intervention.
So what should nurses be doing?
Changing positions, standing, kneeling, lunging, getting on hands and knees, or using a birthing ball, it dynamically changes the geometric shape of the maternal pelvis.
It opens things up.
Exactly. It opens the pelvic outlet and utilizes gravity to assist the fetus in rotating and descending. Research actually shows that frequent maternal position changes can actively shorten the first stage of labor by more than an hour.
That's huge. Okay, and the final P is psyche, the maternal emotional state. I feel like this one gets brushed off sometimes as just, hey, be nice to the patient. But it's actually a physiological mechanism, isn't it? Like, if a patient is terrified, their body physically fights the labor.
It is a profound biochemical reaction. If a patient experiences intense fear, anxiety, or lack of support, their sympathetic nervous system activates.
It's fight or flight response.
Exactly. Their adrenal glands dump massive amounts of catecholamines, epinephrine, and norepinephrine into their bloodstream.
And what does that do to the uterus?
Epinephrine binds to beta receptors in the smooth muscle of the uterus, which actually relaxes the muscle and halts the contractions.
Wow.
From an evolutionary standpoint, if a predator is attacking, the body shuts down labor so the mother can run away.
That makes total sense biologically.
Right. So the nurse's role in providing support, reducing anxiety, managing pain, and welcoming care partners is not just a customer service initiative. It is a vital physiological intervention to keep the primary powers functioning.
Okay, so we have the 5 Ps: passenger, passage, powers, position, psyche.
Got 'em.
Clinically, you will constantly be asked to triage patients who come into the hospital reporting that they're in excruciating pain and claiming they are in labor.
Happens all the time.
And this is where the physiology of the uterus becomes a massive liability, because you have to differentiate between true labor and false labor.
Yes, the triage dilemma.
If I send a true labor patient home, I have committed a massive safety violation. If I admit a false labor patient, I'm setting them up for a cascade of unnecessary medical interventions. So what is the undeniable gold standard metric to tell the difference?
Cervical change. Period.
Just that one thing.
Yes. True labor is defined by one absolute objective metric: progressive cervical dilation and effacement caused by uterine contractions. Those contractions must progressively increase in frequency, duration, and intensity.
But what about Braxton Hicks contractions? Because they feel incredibly real to the patient. Why do they happen if they aren't actually dilating the cervix?
Well, Braxton Hicks contractions are localized spasms of the uterine muscle fibers. They are essentially the uterus practicing or toning its muscle throughout the pregnancy.
Getting ready for the big day.
Exactly. They are often triggered by dehydration, a full bladder, or physical activity, but they lack the organized, downward-sweeping electrical pacing of true labor.
So they don't do the turtleneck pulling.
No, they don't. They occur randomly, they don't increase in intensity, and most importantly, they do not possess the mechanical force required to pull the cervix open.
So how does the nurse differentiate them during an assessment?
With true labor, the contractions usually originate in the lower back, radiate around to the lower abdomen, and feel like intense, deep menstrual cramping. But the definitive differentiator is the response to intervention. True labor contractions are relentless. They do not stop with rest, they do not stop with hydration, and they do not stop if you walk around. They keep coming.
And false labor.
False labor contractions are often described as mild cramps or just an uncomfortable tightening across the top of the belly. And they will typically fade away if the patient lies down, drinks a large glass of water, or takes a warm shower.
I actually use an analogy for this.
Oh, let's hear it.
I compare false labor to a car engine revving while the transmission is in neutral. You know, you hear a lot of noise, you feel the engine vibrating, the car is definitely doing something.
But you're not going anywhere.
Exactly. The wheels aren't turning, you aren't moving an inch forward. That's false labor. No forward progress, no cervical change.
I love that.
True labor is when you shift that car into drive. Every single rev of the engine moves you closer to the destination.
That perfectly captures the mechanics.
So, putting on my nursing student hat, let me throw an exam scenario at you.
Bring it on.
A patient comes into triage. She is crying, she is clutching her abdomen, and she states her contractions are a 10 out of 10 on the pain scale. She must be in true labor, right? We need to admit her immediately.
That is one of the most common traps on the NCLEX and in real life. Do not ever assume that intense pain equals true labor.
Why not? She's at a 10 out of 10.
Because pain is entirely subjective and heavily influenced by that fifth P, psyche. Severe anxiety can make a Braxton Hicks contraction feel agonizing, but the nurse cannot admit a patient based on a pain score alone.
Right.
The only objective finding that confirms true labor is cervical change. You must perform a sterile vaginal exam. If her cervix was 2 centimeters yesterday at her clinic appointment, and you check her in triage today and it's still 2 centimeters...
Despite her being in 10 out of 10 pain.
Exactly. She is not in true labor.
The engine is just revving in neutral.
Yep.
Okay, so if you only remember 5 things for this first topic, what are the takeaways that will keep a future nurse safe on the floor?
Number 1, true labor creates cervical dilation and effacement. Number 2, false labor stops with rest and hydration. True labor does not.
Right. Number 3, the ideal fetal attitude is complete flexion, the vertex presentation.
Number 4, maternal position changes actively shorten the first stage of labor. And number 5, the 5 Ps must work in harmony for a successful vaginal birth.
That is the foundation of obstetric triage right there.
Absolutely.
So let's say we've done our triage. The contractions are regular, the engine is in drive, and the cervix is actively transforming. We know the patient is in true labor.
Okay, we're admitting her.
Now, we need to physically measure that progress in detail, and we need to check the environment the baby is currently living in. How do we track the physical descent?
This requires a highly systematic physical assessment. When a nurse performs a sterile vaginal cervical exam, they are not just checking one thing. They are measuring 3 specific distinct data points.
Which are?
Dilation, effacement, and station. Let's break down the mechanics of each.
Okay, let's start with dilation.
Dilation is the widening of the internal cervical opening. We measure this subjectively with our fingers in centimeters, from 0 to 10. 0 means the cervix is completely closed. 10 centimeters is fully dilated.
Well, what does 10 centimeters actually feel like? Like, do you just feel a giant hole?
Actually, at 10 centimeters, you essentially feel nothing.
Nothing.
Right. The cervix is completely retracted up and around the fetal head. When you sweep your fingers around the presenting part, you should not be able to palpate any cervical lip.
And if you do feel a lip?
If you can still feel a rim of tissue, even just a tiny piece, she is not 10 centimeters, and she should not start pushing yet.
Why is pushing early so dangerous?
If she pushes against an undilated cervix, it can swell, tear, or hemorrhage. It's a huge safety issue.
Okay, that makes sense. Wait until it's completely out of the way.
Yeah.
And then we have effacement, which is the thinning of the cervix. A normal, non-laboring cervix is a thick, muscular tube, right? Like about 2.5 to 3 centimeters long.
Correct.
How does it just vanish?
It's an enzymatic and mechanical process. Prostaglandins break down the collagen network within the cervix, softening it. Then, as the longitudinal muscle fibers of the uterus contract, they physically pull the internal cervical us upward.
The turtleneck again?
Yes. The cervix shortens and thins out. We measure this in percentages. So 0% effaced means the cervix is still its original thick 3-centimeter self.
Okay.
50% means it has thinned to about half its length. And 100% effaced means the cervix is completely paper thin, like a tight rubber band stretched around the baby's head.
And the third measurement is station. This measures the descent of the fetal presenting part through the maternal pelvis. The landmark we use here is the maternal ischial spines.
Right. The ischial spines are 2 bony prominences that jut inward into the pelvic cavity. They represent the narrowest diameter of the pelvic outlet.
Okay, I have to push back on the numbering system for station because it is universally confusing for students.
It trips everyone up.
Station is measured from -5 to +5. Feels completely backwards. If the baby is high up in the pelvis, shouldn't that be a positive number? Why do negative numbers mean the baby is high up, while positive numbers mean they are closer to coming out?
It is entirely counterintuitive until you reframe how you look at the pelvis.
Okay, reframe it for me.
Think of the ischial spines, that narrowest bony choke point, as the 0 point. They are the toll booth on the highway to birth.
The toll booth, okay.
Everything is measured relative to that toll booth. If the baby's head is high up in the abdomen above the ischial spines, they haven't reached the toll booth yet. They're in the negative zone.
Ah, so they have a negative amount of progress.
Exactly. -3, -2, -1. They are approaching, but they are not engaged in the tightest part of the pelvis.
Okay, so 0 station means?
0 station means the absolute widest part of the fetal head is exactly level with those bony ischial spines. The head is officially engaged. They are at the toll booth.
And once they pass the toll booth?
Then they are making positive progress toward the outside world. +1, +2, +3. By the time they reach +4 or +5, the head is crowning at the vaginal opening.
Okay, so a great memory anchor for this is, Negative is nowhere near, positive is popping out.
That is brilliant. Yes.
Yeah.
Negative is nowhere near, positive is popping out.
So on a chart, if a provider writes an exam as 581,
That translates to the cervix is 5 centimeters dilated, it is 80% effaced, and the baby's head is 1 centimeter above the ischial spines.
you've got it. Now, alongside the cervical exam, the nurse must assess the status of the amniotic membranes.
The water breaking.
Right. The amniotic sac is a balloon of fluid surrounding the baby. Sometimes it ruptures spontaneously during labor. Other times, the provider will use a plastic hook to perform an amniotomy to artificially rupture the membranes and speed up labor.
Either way, the exact second those membranes rupture, the entire clinical picture shifts and the nurse's priority changes instantly.
Let's explain the why behind that shift. Why is a ruptured membrane such a massive turning point?
Because the amniotic sac is a sterile physical barrier. It protects the highly vulnerable sterile fetus from the outside world, specifically the bacterial flora of the vagina.
Right.
Once that sac ruptures, the barrier is gone. A direct pathway to the fetus is open, and a biological clock starts ticking on infection.
And what about the physical mechanics of the fluid leaving?
That's the other huge risk. The sudden, massive rush of fluid flowing out of the uterus creates a physical current. That current can actually sweep the umbilical cord down past the baby's head, trapping it.
So let's talk about the fluid itself. What are we looking for? What are the expected versus concerning findings when the water breaks?
Expected findings are pretty straightforward. The amniotic fluid should be mostly clear, maybe slightly cloudy.
Yeah.
You might see small white flecks floating in it, which is vernix, the protective cheese-like coating on the baby's skin. It has a very thin, watery consistency and a very slight fleshy or musty odor. It shouldn't smell repulsive.
And the priority concerning findings, the things that require immediate escalation.
First is color. If the fluid is green, yellow, or a dark, thick, brownish green, that is a massive red flag.
Why?
That indicates the fetus has passed meconium in utero.
Meconium is the baby's first bowel movement, right?
Yeah.
It's usually this thick, sticky black tar. Why is it so dangerous if it's floating in the fluid?
Because the baby is breathing that fluid in and out of their lungs to practice respiration. If the fluid is full of thick, sticky meconium, the baby draws that tar deep into their alveolar spaces.
Oh.
Yeah. When they are born and take their first breath of air, that meconium physically plugs the airways and chemically deactivates the surfactant in their lungs. It causes severe chemical pneumonitis, known as meconium aspiration syndrome. It can be fatal.
And what causes the baby to pass meconium before birth anyway?
It is almost always a sign of fetal stress. Often it's chronic hypoxia.
Lack of oxygen.
Right. When the fetus doesn't get enough oxygen, their autonomic nervous system triggers a vagal response. Blood is shunted away from the gut to protect the brain, the intestinal peristalsis increases, and the anal sphincter relaxes, dumping the meconium into the fluid.
Okay, so green fluid is a major aspiration and hypoxia risk. What else are we looking for?
Odor. If the fluid has a foul, purulent, or rotten odor, it screams infection, specifically chorioamnionitis, an infection of the chorion and amnion layers of the sac.
Makes sense.
And finally, you must assess the station of the baby when the water breaks. If the membranes rupture while the baby is floating high up at a -3 station, there is a massive volume of fluid beneath the head.
So that breaks.
When that fluid rushes out, it's highly likely to wash the umbilical cord down into the vagina.
Which leads us directly to the most critical NCLEX and clinical priority question for this entire topic.
Oh, this is the big one.
A patient is laboring. She suddenly says, I just felt a pop and a huge gush of fluid. What is the very first immediate action the nurse must take? Do you grab towels to clean her up? Do you look at the fluid color? Do you check her temperature?
No, you do absolutely none of those things first.
Okay, what do you do?
The very first, absolute, non-negotiable priority action is to assess the fetal heart rate. You must immediately look at the monitor and check the FHR.
Because of the cord?
Yes. If that rushing fluid swept the umbilical cord down, the heavy, bony head of the fetus is going to slam down onto the pelvic bone, completely crushing the cord between them.
Cutting off the blood.
Exactly. Blood flow from the placenta to the baby will stop instantly. If that happens, the fetal heart rate will plummet. You will see a sudden, profound bradycardia or a severe variable deceleration.
Wow.
Assessing the FHR is the only way you can instantly rule out a prolapsed cord. Once you confirm the heart rate is stable, then you can look at the color of the fluid and grab the towels.
Assess the heart rate first.
Yeah.
Always.
Oh,
Once that's done, you mentioned the ticking clock on infection. How does our vital sign protocol change?
before rupture, you might check a maternal temperature every 4 hours. The moment the membranes rupture, that changes to every 2 hours.
Because the sterile seal is broken.
Exactly. You are hunting for the earliest signs of chorioamnionitis, maternal fever, fetal tachycardia, a tender uterus, or foul-smelling fluid.
And speaking of infection, this is where Group B streptococcus, or GBS, becomes a critical factor. The guidelines state that all pregnant clients should be swabbed and tested for GBS between 36 and 37 weeks gestation.
Yes, standard prenatal care.
But if GBS is just a normal bacteria, why is it such a high priority?
Because of the massive difference between maternal and fetal immune systems. GBS is a naturally occurring bacterium that lives in the lower GI or genital tract of about 25% of healthy women.
So the mom is totally fine.
To an adult with a mature immune system and intact mucosal barriers, it is completely harmless. They don't even know they have it. But a fetus has a naive, immature immune system. They have no IgG or IgA antibodies to fight it.
So if they are exposed during birth,
If a baby inhales or swallows GBS bacteria as they slide through the birth canal, the bacteria rapidly invades their bloodstream and lungs. It causes devastating neonatal sepsis, pneumonia, and meningitis within hours of birth.
so what is the nursing intervention? I mean, we can't just sterilize the birth canal.
No, we use targeted pharmacology. The priority intervention is administering prophylactic intravenous antibiotics, usually penicillin G or ampicillin, to the mother during labor.
To the mother, not the baby.
Right. We want the antibiotic in the mother's bloodstream, so it crosses the placenta and builds up therapeutic levels in the fetal bloodstream before they pass through the canal.
What if a patient comes in active labor and they had no prenatal care, so we don't know their GBS status?
You treat them prophylactically if they have specific clinical risk factors. If their water has been broken for more than 18 hours, if they have a fever over 100.4, or if they are in preterm labor before 37 weeks, you hang the antibiotics. The risk of untreated GBS sepsis far outweighs the risk of the antibiotic.
Okay, one more clinical scenario on this topic.
Right.
A patient comes into triage complaining of wet underwear. She thinks her water broke, but she's not sure.
Happens every day.
Right. Maybe it's just urine, or maybe it's just the heavy vaginal discharge, common in late pregnancy. How does the nurse definitively prove it's amniotic fluid?
We rely on chemistry, specifically pH levels. The nurse will perform a nitrazine test.
How does that work?
Normal vaginal secretions are highly acidic, maintaining a pH of around 4.5 to 6.2. This acidity is created by lactobacilli bacteria producing lactic acid to prevent infections.
Okay.
Amniotic fluid, however, is mostly composed of fetal urine and lung secretions. It is strictly alkaline, with a pH of 7.1 to 7.3.
So you take a strip of nitrazine paper, which is pH sensitive, and you touch it to the fluid pooling in the vagina.
Exactly. If the fluid is acidic vaginal discharge, the paper stays yellow or olive green. But if the fluid is alkaline amniotic fluid, the paper will instantly turn a deep dark blue.
So blue means broken.
Yes. A blue strip confirms rupture of membranes. You can also take a swab of the fluid, smear it on a glass slide, and look at it under a microscope. As amniotic fluid dries, the sodium chloride in it crystallizes into a beautiful, distinct pattern that looks exactly like a fern leaf. That's called a positive fern test.
But exams love to test the limitations of diagnostic tools. Is there a trap with the nitrazine paper?
A major one. Nitrazine paper can give you a false positive. You cannot trust it blindly.
Why?
Because there are other alkaline substances that can be present in the vagina. Blood is alkaline, semen is alkaline, even some types of bacterial infections alter the pH. If the patient recently had intercourse, or if she is bleeding slightly from cervical dilation, the paper will turn blue even if the amniotic sac is perfectly intact. The nurse must assess the whole clinical picture.
Okay, so let's synthesize this. If we only remember 5 things about assessing progress in fluid, what are they?
1. Station 0 means the fetal head is engaged at the ischial spines. 2. Always check the FHR immediately after membranes rupture.
All right. 3. Meconium stained or green fluid is a major aspiration risk.
4. Temp checks become every 2 hours post-rupture due to infection risk. And 5. GBS positive means antibiotics during labor.
Awesome. That is exactly how a safe nurse prioritizes their assessment.
Exactly.
So the cervix is opening, the water is broken, and we've ruled out a cord prolapse. But labor is a marathon. To safely monitor the baby going forward, we need to know exactly how they are positioned inside the uterus, and we need to evaluate the strength and frequency of the maternal contractions.
We need to monitor the engine.
Right. How do we ensure we are getting accurate data?
Accurate data relies entirely on the correct placement of our sensors. And you cannot place the sensors correctly if you don't know the physical layout of the fetus inside the abdomen. To map that out, the nurse performs the Leopold maneuvers.
Why not just wheel in an ultrasound machine? Why are we using our hands?
An ultrasound is definitive, yes, but in a busy triage unit, you don't always have an ultrasound tech instantly available, and you need to get the fetal heart rate on the monitor immediately. The Leopold maneuvers are a highly tested 4-step physical palpation process that gives the nurse instant data about the fetal lie, presentation, engagement, and attitude. And most importantly, it tells you exactly where the baby's back is located.
Why is the baby's back so important for the monitor?
Because the fetal heart is located in the chest, but the chest is folded inward, muffled by the baby's arms and legs.
Oh, because they're flexed.
Right. The clearest, most unobstructed acoustic pathway to hear the fetal heart valves snapping shut is directly through the smooth, firm surface of the fetal back, between their shoulder blades.
So if you put it in the wrong spot.
If you just guess and slap the ultrasound transducer onto the mother's belly, you might pick up the mother's own aortic pulse, or you might get a broken, terrifyingly spotty signal that makes you think the baby is dying when they are actually fine. You must find the back.
Walk us through the physical mechanics of the 4 steps. What are my hands actually doing?
First, you stand beside the bed facing the patient. You place both hands firmly on the fundus, the very top of the uterus. You are feeling to determine what anatomical part is up there.
Okay, looking for the head or the butt?
Right. A fetal head will feel hard, perfectly round, and it will move independently of the body. If you tap it, it bobs. If the baby is head down, you will feel the buttocks at the fundus. The buttocks feel softer, irregular, less symmetrical, and they move with the rest of the trunk.
Step 2.
You move your hands down to the sides of the maternal abdomen. You apply firm, steady pressure. You are trying to distinguish the sides. On one side, you will feel a smooth, continuous, convex curve. That is the fetal back.
And that is where your monitor goes.
Exactly. On the opposite side, you will feel knobby, irregular, lumpy protrusions. Those are the small parts, the elbows, knees, and feet.
Step 3.
You take your dominant hand and grip the lower abdomen, just above the maternal pubic symphysis, using your thumb and fingers. You are palpating the presenting part, usually the head. You try to wiggle it gently.
What does the wiggling tell you?
If the head moves freely, it is unengaged. It is floating above the ischial spines. If it is locked firmly in place and cannot be moved, it is engaged at 0 station.
And the final step.
You physically turn your body to face the patient's feet. You place your hands on both sides of the lower uterus and slide your fingers downward toward the pelvic inlet. You are feeling for the cephalic prominence, basically, the baby's brow line.
Which tells you the attitude.
Exactly. If you feel the prominence on the same side as the baby's small parts, the head is beautifully flexed. If you feel it on the same side as the back, the head is extended and you have a problem.
But before the nurse even touches the patient's abdomen to do this, there are 2 crucial priority safety actions.
Yes. First, you must have the patient completely empty her bladder.
Just for her comfort.
Partially for comfort, because deep palpation on a full bladder is agonizing. But clinically, a full distended bladder acts like a water balloon sitting right in front of the lower uterus. It physically displaces the uterus upward and to the side. It will give you a completely false reading of the fetal station and position. The bladder must be empty. Second, and this is a matter of life and death, never leave a pregnant patient flat on her back.
Supine hypotension syndrome. This is foundational to obstetric safety. Walk us through the exact anatomical cascade of what happens when a laboring woman lies flat on her back.
In late pregnancy, the gravid uterus, the fetus, the placenta, and the amniotic fluid weigh a significant amount. When the patient lies supine, gravity pulls that entire massive weight directly downward, compressing the inferior vena cava and the descending aorta against the maternal spine.
The inferior vena cava is the massive vein returning all the deoxygenated blood from the lower body back to the right atrium of the heart, right?
Exactly. When you crush that pipe, venous return drops to almost nothing. If blood isn't returning to the right side of the heart has nothing to pump out. Maternal cardiac output plummets.
So her blood pressure tanks.
Instantly. She will feel dizzy, nauseous, sweaty, and lightheaded. But the most dangerous consequence is invisible.
What happens to the baby?
If maternal blood pressure drops, the hydrostatic pressure required to force oxygenated blood through the uterine arteries into the placenta is lost. The placenta is starved of blood, and the fetus immediately begins suffocating.
So what is the immediate life-saving nursing intervention?
It is incredibly simple. You must physically displace the weight of the uterus off those vessels. You place a wedge, a rolled-up blanket, or a pillow under the patient's right hip to tilt her slightly to the left.
So she's not totally on her side, just wedged.
Right. A 15 to 30-degree tilt is enough to roll the heavy uterus off the vena cava, restoring venous return and saving the fetal oxygen supply.
Okay, so she is wedged, her bladder is empty, we've done our Leopold, and we found the smooth curve of the fetal back.
Well,
We placed the ultrasound transducer there to capture the heart rate. Then we placed the TOCO monitor, the two-catenometer, on the fundus at the top of the uterus to measure the primary powers, the contractions.
right. The TTOCO is an external pressure sensor. We strap it to the abdomen over the fundus because the fundus is the thickest part of the uterine muscle and the pacemaker where contractions begin. The TOCO measures two main parameters, frequency and duration.
Let's clarify the definitions, because this is an easy place to lose points on an exam. Frequency is measured from the start of one contraction to the start of the very next contraction.
Exactly, start to start.
It is not the end of one to the start of the next. It tells us how often they are happening, usually measured in minutes. Duration is measured from the start of a single contraction to the end of that same contraction. It tells us how long the muscle is actually squeezing, measured in seconds.
Perfect definitions. Now, clinically, monitoring these contraction patterns is not just about seeing how fast labor is going. It is entirely about monitoring placental perfusion.
Let's explain that mechanism. Why is the contraction pattern a matter of fetal survival? Why can't the uterus just stay contracted for 10 minutes and squeeze the baby out like toothpaste from a tube?
Because of the unique vascular anatomy of the placenta, the maternal-fetal interface in the placenta is essentially a giant pool of maternal blood in the intervillous space. The mother's spiral arteries pump fresh, oxygenated blood into this pool, and the fetal capillaries bathe in it, picking up the oxygen.
Okay, makes sense.
But those maternal spiral arteries travel directly through the thick wall of the uterine muscle.
So when the muscle contracts,
When the myometrium tightens during a contraction, it violently squeezes those spiral arteries shut. It completely occludes them. Blood flow from the mother to the placenta is temporarily halted. The pool stops refilling.
so the baby gets no fresh oxygen during a contraction.
Exactly. This causes a period of transient fetal hypoxia. The baby essentially has to hold its breath and survive on whatever oxygen is already in the placental pool for the entire duration of the contraction.
Wow, so the relaxation period, that soft resting tone between the contractions, is not just a break for the mother's pain. It is the only time the baby gets to take a breath and recover their oxygen levels.
Exactly. The resting tone is the lifeline. A healthy fetus has physiological reserves and can tolerate this temporary drop in oxygen perfectly fine, provided they get enough time to recover. We expect to see 3 to 5 contractions in a 10-minute window, with each lasting maybe 60 to 90 seconds.
But if they come too fast?
If the contractions are coming too fast or lasting too long, the baby gets 0 recovery time. The pool never refills.
Which brings us to a massively important concerning finding. Tachysystole. The text defines tachysystole as more than 5 contractions in a 10-minute period, averaged over a 30-minute window.
More than 5 in 10 is a clinical emergency. It means the uterus is hyperstimulated, the muscle is spasming, the spiral arteries are constantly restricted, and the resting tone is obliterated.
So the baby is basically drowning.
Sustained tachysystole will rapidly deplete the fetal oxygen reserves, leading to severe fetal hypoxia, metabolic acidosis, and brain injury. You are mechanically starving the fetus of oxygen.
Now, I want to talk about measuring the strength or the intensity of these contractions. The text is very specific about an exam trap here. A lot of students, and even some new nurses, think that the external TOCO monitor tells you how strong a contraction is by how high the little mountain goes on the graph paper.
That is a fundamental misunderstanding of the equipment, and exams test it constantly. An external TOCO cannot, under any circumstances, measure the true strength or intensity of a contraction. It only measures frequency and duration.
So the height of the line doesn't matter.
The height of the line on a TOCO strip is completely subjective. It is affected by the thickness of the maternal abdominal fat pad, how tightly you strap the belt on, whether the patient coughs, or if she vomits. It is literally just a plastic button sensing pressure against the outside of the abdominal wall.
I have a perfect analogy for this.
Let's hear it.
Relying on an external TOCO is like pressing your hand flat against a closed, solid oak door to feel if someone on the other side is knocking. You can feel the vibration, so you know exactly when they are knocking. You know exactly how long they knock. But because of the thick door, you really can't tell exactly how hard they are hitting the wood. If you want to know the true acoustic intensity, you need to put a microphone actually inside the room.
That's a phenomenal analogy. And in obstetrics, that internal microphone is the intrauterine pressure catheter, or the IUPC.
How does that work?
The IUPC is a sterile, flexible, fluid-filled catheter. The provider inserts it vaginally, threads it up through the dilated cervix, and places it directly into the uterine cavity, resting right next to the baby.
So it's inside the room.
Exactly. Because it is inside the sealed environment, it can accurately measure the exact internal hydrostatic pressure generated by the contracting muscle. It measures intensity in highly specific units called Montevideo units, or millimeters of mercury.
But there is a catch. You can't just put an IUPC in anyone.
Correct. Remember our rule about barriers. To place an IUPC, two things must be true. The cervix must be dilated enough to physically pass the catheter, and the amniotic membranes must be ruptured. You cannot slide a catheter inside a sealed balloon.
Right. Okay, let's hit our 5 takeaways for monitoring the engine.
Number 1, empty the bladder before Leopold maneuvers. Number 2, never leave a pregnant patient flat on their back to avoid supine hypotension.
Number 3, contraction frequency is measured from the start of one to the start of the next.
Number 4, Taxicely, which is more than 5 and 10 minutes, starves the fetus of oxygen. And number 5, only an IUPC can accurately measure the intensity of a contraction.
Okay, that is the core of maternal assessment. So our monitors are correctly placed, the TCO is tracking the timing of the contractions, the ultrasound is locked onto the fetal back, tracking the heart rate. Now we pull up a chair and we look at the screen. What is the baby's heart telling us about their brain?
We have arrived at the holy grail of obstetric nursing exams.
Yes, fetal heart rate monitoring and categories. This is, without a doubt, the most highly tested, highly stressful area in all of OB nursing.
And rightfully so. Fetal heart rate monitoring is the only tool the nurse has to determine if the fetus is thriving in a healthy environment or if they are actively dying of asphyxiation.
No pressure.
Right. You must be able to glance at a strip, analyze the components, synthesize them into a category, and know instantly whether to document and observe or whether you need to pull the emergency alarm.
Let's break down the individual components of the strip systematically. We have the baseline, the variability, accelerations, and decelerations. First, the baseline FHR.
The baseline is the average heart rate when the baby is not stressed by a contraction. The expected normal baseline fetal heart rate is between 110 and 160 beats per minute. The nurse assesses this by looking at a 10-minute window of the strip and finding the mean rate, excluding any temporary spikes or drops.
What if the baseline drifts outside that window? Like, what if it's too high or too low?
If the baseline heart rate is consistently below 110 for more than 10 consecutive minutes, that is officially defined as fetal bradycardia. If it is consistently above 160 for more than 10 minutes, that is fetal tachycardia.
And what do those extremes physically mean? The text mentions tachycardia can actually be an early warning sign of a maternal issue.
Absolutely. Fetal tachycardia is often the very first sign of a maternal infection, like chorioamnionitis. As the mother's temperature rises, the fetal metabolic rate skyrockets, and their heart races to keep up.
Makes sense, like a fever in an adult.
Exactly. It can also be an early compensatory mechanism for fetal hypoxia. The heart beats faster to try and circulate whatever meager oxygen is left. Bradycardia, on the other hand, is a late and dire sign.
It's failing.
Right. It means the compensatory mechanisms have failed. The heart muscle itself is starved of oxygen, and it is failing. It is often associated with a massive cord prolapse, a placental abruption, or terminal hypoxia.
But the baseline is just the broad average. The real diagnostic magic, the most critical indicator of fetal well-being on that entire monitor, is variability.
Yes. Variability is the nuance. It refers to the squiggly lines on the monitor. If you look closely at a healthy fetal heart rate tracing, it is never a perfectly flat, straight line. It looks like a jagged sawtooth. It constantly jitters up and down, beat to beat.
What biological mechanism causes that jitter?
That jitter is the physical manifestation of the fetal central nervous system at work. Specifically, it is the constant microscopic tug of war between the sympathetic nervous system, which is trying to speed the heart up, and the parasympathetic nervous system, which is trying to slow it down.
So they're just constantly fighting for control.
Yes, they are constantly fighting for control based on momentary changes in blood pressure and oxygen.
And the text says that moderate variability is the absolute goal.
Moderate variability means the heart rate fluctuates between 6 and 25 beats per minute around the baseline. It is the holy grail of fetal monitoring.
Because it proves the brain is working.
Exactly. If you see moderate variability, it guarantees two vital physiological facts. The fetal central nervous system is fully intact and functioning, and the fetal brain is adequately oxygenated. The baby is not profoundly hypoxic, and they are not acidotic. It is the single most reassuring sign you can have.
What if those squiggles start to flatten out? Minimal variability is defined as less than 5 beats of fluctuation, and absent variability is a completely flat, ruler straight line. No squiggles at all. I have a clinical question about this. If the variability goes completely flat, is the baby always in mortal danger, or can they just be, well, taking a nap?
That is a phenomenal question, and it requires sharp clinical judgment. It is true that a fetus has sleep cycles, and when they sleep, their central nervous system activity naturally depresses, which can cause minimal variability for about 20 to 40 minutes.
Okay, so sleep causes minimal.
Right. Furthermore, if the nurse just administered an opioid analgesic to the mother, or if she is on a magnesium sulfate drip for preeclampsia, those central nervous system depressants easily cross the placenta. They put the baby's nervous system to sleep, causing minimal variability.
So minimal variability can be pharmacological or physiological. But what about absent variability, the flat line?
Absent variability is never, ever considered a normal sleep cycle. A perfectly flat line means the tug-of-war has stopped entirely. The autonomic nervous system has shut down.
That's terrifying.
It is. If absent variability is combined with decelerations in the heart rate, it means the fetal brain is suffering from severe hypoxia and metabolic acidemia. The acid is literally depressing the brain tissue. It is a critical emergency.
Okay, so we want moderate squiggles to prove the brain is oxygenated. Now let's talk about the big jumps above the baseline. Accelerations.
Accelerations are abrupt, temporary increases in the fetal heart rate. For a term baby over 32 weeks gestation, we are looking for a jump of at least 15 beats per minute above the baseline, and that jump must last for at least 15 seconds before returning to normal. This is known universally as the 15 by 15 rule.
And accelerations are always a good thing, right? There's no such thing as a dangerous acceleration.
Always good. Accelerations mean the baby has robust oxygen reserves. When the baby kicks, rolls, or gets stimulated, their heart rate jumps up to supply the muscles with oxygen, just like your heart rate jumps when you sprint up a flight of stairs. It proves the cardiovascular system is highly responsive and healthy.
Now we enter the complicated territory, the drops, decelerations. The text breaks these down into 4 highly specific types based on their shape and their timing relative to the maternal contractions: early, late, variable, and prolonged.
This is where exams absolutely love to trap students.
Let's start with early decelerations.
Early decelerations have a very specific visual profile. They are gradual, smooth drops in the heart rate that perfectly mirror the maternal contraction. They are symmetrical.
So they match up exactly.
Yes. As the uterine contraction begins to build, the fetal heart rate smoothly begins to drop. At the exact moment the contraction hits its absolute peak intensity, the heart rate hits its lowest point, the nadir. And as the contraction fades away, the heart rate smoothly returns to baseline. They start together, they peak together, and they end together. They look like a reflection in a pond.
What is the physiological cause of that perfect mirroring? Is the baby being suffocated by the contraction?
No, it is not an oxygen issue at all. It is a mechanical pressure issue. Think about what happens as the fetus descends low into the maternal pelvis. The bony head is squeezed tightly by the contracting uterus and the rigid pelvic bones.
Ouch.
Right. This intense physical compression of the skull increases the fetal intracranial pressure.
And increased pressure in the brain does what to the heart?
It triggers a protective reflex. The high pressure stimulates the fetal vagus nerve. The vagus nerve fires a signal directly to the heart to slow down. It's essentially the fetal version of the Cushing reflex. The moment the contraction ends and the pressure on the skull is released, the vagus nerve stops firing and the heart rate returns to normal.
Because it is an expected mechanical vagal response to the head being squeezed in the birth canal, It isn't dangerous.
Exactly. Early decelerations are completely benign. They do not indicate hypoxia. They do not cause brain damage. In fact, they usually just tell the nurse that the baby is descending nicely and labor is progressing.
So what does the nurse do?
Therefore, early decelerations do not require any medical or nursing intervention. You do not touch the patient. You just document the finding and continue to observe.
So a classic exam trap would present a scenario with early decelerations and offer multiple choice answers like administer oxygen, turn the patient, or prepare for surgery. The educated nurse has to recognize the shape, know the physiological cause is head compression, realize it's benign, and confidently choose the answer, document findings.
Exactly. Do not intervene for an early
But late decelerations are a completely different, terrifying story.
Late decelerations look very similar to early decelerations in their shape. They are smooth, gradual, and symmetrical. But their timing is shifted to the right on the graph paper.
What do you mean shifted to the right?
The fetal heart rate does not even begin to drop until after the maternal contraction has reached its peak. And the heart rate does not recover back to baseline until well after the contraction is completely over and the uterus is resting.
Why the delay? Let's connect this back to our deep dive on contraction hemodynamics and the placenta.
Remember how a contraction acts like a vice, clamping down on the maternal spiral arteries and temporarily stopping blood flow to the placental pool?
Yes, the baby holds its breath.
A healthy placenta is robust. It holds enough reserve oxygen in that pool to easily tide the baby over during that 60-second squeeze. The baby's blood oxygen levels remain stable, so the heart rate remains stable.
But what if the placenta is failing? What if the mother has severe preeclampsia or hypertension, or she's a heavy smoker, and those spiral arteries are already calcified and damaged?
That is called uteroplacental insufficiency. The placenta is compromised. It has zero oxygen reserve. So when the contraction peaks and cuts off the fresh blood flow, the oxygen in the placental pool is instantly depleted. The fetal blood oxygen level drops precipitously.
So why doesn't the heart rate drop the exact second the blood is cut off? Why the late delay?
Because of circulation time. The oxygen drops in the placenta. It takes several seconds for that deoxygenated hypoxic blood to travel down the umbilical vein, enter the fetal body, pass through the fetal liver, enter the fetal heart, and finally get pumped up to the fetal brain.
Oh, wow. That's a long journey.
Right. Once that hypoxic blood reaches the brain, specialized chemoreceptors in the aortic, arch, and carotid bodies detect the sudden lack of oxygen. They panic. They trigger the vagus nerve to slow the heart down, hoping to drastically reduce the heart muscle's demand for oxygen and conserve energy.
That is fascinating. The delay is literally the time it takes for the suffocating blood to travel from the placenta to the baby's brain chemoreceptors.
Precisely. That is why it is a late deceleration. It is a delayed neurological reaction to suffocating. Late decelerations mean the placenta is failing to do its job. It is an ominous sign, and it requires immediate, aggressive nursing intervention to restore maternal blood flow.
Okay, so earlies are head compression, benign. Lates are uteroplacental insufficiency, highly dangerous. What about variable decelerations?
Variable decelerations are an entirely different beast. They do not look smooth, they are not gradual, and they are not necessarily tied to the timing of the contraction at all.
What do they look like?
They are abrupt, sharp, jagged drops in the heart rate. They look like a sharp letter V, a U, or a W on the monitor. The heart rate plummets instantly, and it usually bounces back just as fast.
And what's the physiological cause driving that sharp drop?
Umbilical cord compression. The umbilical cord is the baby's only lifeline, containing one vein and two arteries. If that cord gets squeezed, maybe the baby grabs it with their hand or rolls over onto it, or perhaps the amniotic fluid is too low to adequately cushion it, the blood vessels inside collapse.
Walk me through the hemodynamics of that collapse because it explains the shape.
The umbilical vein, which carries oxygenated blood to the baby, has a thin, floppy wall. When the cord is squeezed, the vein collapses first. This cuts off blood return to the fetal heart, causing fetal cardiac output to drop.
Okay.
The fetal baroreceptors detect this drop in pressure and trigger a slight compensatory spike in the heart rate. But a millisecond later, the thick-walled umbilical arteries collapse. Suddenly, the fetal heart is pumping against a brick wall. Fetal blood pressure skyrockets massively. The baroreceptors scream in panic, and the vagus nerve fires a massive impulse, plummeting the heart rate abruptly to protect the heart from exploding under the pressure. When the pressure on the cord is released, the sequence reverses, and the heart rate shoots right back up.
That explains the jagged, abrupt nature of the variable deceleration. It's a rapid-fire vascular pressure crisis. Okay, and finally, prolonged decelerations.
A prolonged deceleration is simply a profound drop in the heart rate, at least 15 beats per minute below baseline. That lasts for longer than 2 minutes, but less than 10 minutes. If it lasts longer than 10 minutes, remember that's no longer a deceleration, that is a permanent baseline change to bradycardia.
What causes a prolonged decel?
Prolonged decelerations happen when whatever is causing the stress, a cord prolapse, severe tachysystole, or massive maternal hypotension following an epidural placement, is severe and is not resolving on its own.
There's one more pattern the text mentions, and it sounds incredibly ominous. The sinusoidal pattern.
Yeah. It is extremely rare but highly lethal. A sinusoidal pattern looks like a smooth, undulating sine wave. It is perfectly rhythmic, waving up and down like a snake, with absolutely no normal beat-to-beat variability.
What does that mean?
It usually indicates severe, profound fetal anemia. This can happen from a massive fetal maternal hemorrhage, a ruptured vasa previa, or severe Rh isoimmunization, where maternal antibodies are actively destroying the fetal red blood cells. The baby's bleeding out, or their blood is completely incapable of carrying oxygen. It requires immediate emergent surgical delivery.
Okay, this is a massive amount of physiological data to take in. How does the bedside nurse synthesize all these pieces, baseline, variability, accelerations, and decelerations, into actionable clinical steps?
We synthesize the data using the 3-tier categorization system dictated by national guidelines. Every single fetal heart rate strip must be classified as Category 1, Category 2, or Category 3.
Let's define the parameters of Category 1. This is the perfect, healthy strip. The baseline is exactly where it should be, 110 to 160. The variability is moderate, proving the brain is oxygenated. Accelerations can be present or absent. The other is fine. Early decelerations from head compression can be present or absent. But crucially, to be a Category 1, there must be NO late decelerations and NO variable decelerations.
Right. Category 1 is strongly predictive of normal fetal acid-base status. The baby is perfectly fine. The nursing action is simple, routine, continuous, or intermittent monitoring. No intervention is needed.
Skipping over the middle for a second, let's look at the other extreme. Category 3 is the absolute nightmare strip. To be Category 3, you must have absent variability, that completely slat ruler straight line combined with recurrent late decelerations or recurrent variable decelerations or severe bradycardia. Or you see that lethal sinusoidal pattern?
Yes. Category 3 is predictive of abnormal fetal acid-base status. The fetus is actively hypoxic and suffering from metabolic acidemia. The brain is starving. You must intervene aggressively, initiate intrauterine resuscitation immediately, and prepare the operating room for an emergent life-saving cesarean section.
And Category 2 is essentially the catch-all for everything else in between.
Yes, Category 2 is considered indeterminate. It's the gray area. It might show minimal variability, or it might show recurrent variable decelerations, but still maintain moderate variability. It's the warning track.
So what's the nursing action for Category 2?
You don't necessarily rush the patient to the OR right that second, but you absolutely must implement corrective nursing measures, try to fix the underlying physiological issue, and watch the strip like a hawk to ensure it doesn't degrade into a Category 3.
Before we move on to how we actually fix those issues, we need to lock in our pattern recognition for the decelerations. What is the standard mnemonic that every nursing student must memorize to match the deceleration to its physiological cause?
The standard mnemonic used globally in nursing education is VLCHOP. It lines up 4 letters with 4 other letters perfectly. V matches with C, matches with H, A matches with OL, matches with P.
Let's spell it out. V is for variable decelerations, which match with C for cord compression. E is for early decelerations, which match with H for head compression. A is for accelerations, which match with O for atopy. Okay, they are normal. L is for late decelerations, which match with P for placental insufficiency.
VLGCEHAOLP. If you memorize that, you will instantly recognize the physiological root cause of any monitor strip you are given.
Let's give our 5 takeaways for fetal monitoring.
Number 1. Moderate variability is the best predictor of fetal oxygenation. Number 2, accelerations are always good. Number 3, early decelerations mean placental insufficiency and are highly dangerous. And number 5, variable decelerations mean cord compression and look like abrupt V's or W's on the monitor.
So let's put you in the scenario. You are standing at the bedside of a laboring patient. You are staring at the monitor screen, and suddenly you see it. The variability goes completely flat. You start seeing deep, recurrent, smooth, late decelerations long after the contractions end. The baby is suffocating due to placental insufficiency. It is a Category 3 tracing. What do you actually DO?
It's time for emergency protocols. Let's cover saving the day intrauterine resuscitation and emergencies.
This is where critical thinking and rapid physical action save lives. When you see a non-reassuring fetal heart rate pattern, specifically late decelerations, prolonged decelerations, or severe variables, you do not just stand there and observe. You do not wait for the doctor to arrive. You independently initiate a bundle of rapid, targeted interventions called intrauterine resuscitation.
Right. The text defines this as a bundle of actions designed to maximize maternal cardiac output, maximize blood flow to the uterus, and maximize oxygen delivery across the placenta. We are trying to buy time and reverse the hypoxia before permanent brain damage occurs.
There are 4 main interventions: maternal repositioning, increasing IV fluids, administering oxygen, and discontinuing uterotonics. Let's explain the deeper why behind each one, because understanding the mechanism is how you remember them under extreme pressure. First, repositioning the mother.
We touched on this with supine hypotension. If the mother is flat on her back, the vena cava is compressed. Turning the patient to a lateral side-lying position, either left or right, or even getting them up into a hands and knees posture, immediately shifts the massive weight of the gravid uterus off the major blood vessels.
Which instantly restores venous return to her heart.
Exactly. It maximizes maternal preload, which maximizes cardiac output, which dramatically increases the volume of blood being forced into the placental pool. Furthermore, if the monitor is showing variable decelerations from cord compression, physically shifting the mother's position causes the baby to shift position inside the fluid.
That makes sense.
That movement often untangles the cord or takes the baby's heavy body weight off the compressed vessels, restoring fetal blood flow.
Okay, second intervention, increasing intravenous fluids.
The nurse will open the IV roller clamp wide and administer a rapid fluid bolus of an isotonic crystalloid, like lactated ringers or normal saline. Why? Because you want to rapidly and artificially expand the maternal intravascular blood volume.
Because more volume equals more pressure.
Precisely. You are filling the pipes. Higher maternal blood pressure increases the hydrostatic force pushing blood through those tight, constricted spiral arteries and into the intervillous space of the placenta. You are essentially force-feeding blood to the placenta.
Third intervention, administering oxygen. But there's a huge classic exam trap here that catches so many students.
Yes. Do not ever choose the multiple choice answer that says, apply 2 liters of oxygen via nasal cannula. That low flow rate does virtually nothing for a severely hypoxic fetus. Intrauterine resuscitation requires blasting the maternal pulmonary system with oxygen. You must apply a non-rebreather face mask with the oxygen flow meter cranked all the way up to 10 liters per minute.
Why such a massive dose?
Because you aren't just trying to saturate the mother's hemoglobin. Her hemoglobin is probably already 99% saturated. You are trying to drastically increase the partial pressure of freely dissolved oxygen in her blood plasma. By hyperoxygenating the maternal plasma, you create a massive diffusion gradient across the placental membrane, forcing whatever small amount of blood does make it to the placenta to offload a massive payload of oxygen to the baby.
And the fourth intervention, discontinue uterotonics.
Yeah.
This almost always means turning off the pitocin or synthetic oxytocin IV drip.
Think back to our engine analogy and the hemodynamics of a contraction. The uterus is contracting, squeezing the spiral artery shut and cutting off the blood supply. If the baby is suffocating because of those mechanical squeezes, the absolute most logical, immediate thing to do is to stop the squeezing.
Right, turn off the oxytocin.
You must turn off the pharmacological drug that is forcing the uterus to work. Give the muscle a break. Let the pool refill.
But what if the mother isn't on pitocin? What if she is in spontaneous tachysystole, having 7 contractions in 10 minutes all on her own, and the baby is crashing? You can't unplug her own brain.
In that case, you have to use pharmacology to actively paralyze the myometrium, the uterine muscle. The provider will order a stat dose of a tocolytic medication. The most common one mentioned in the text is terbutaline.
How does terbutaline stop a contraction?
Terbutaline is a beta-2 adrenergic agonist. It directly mimics the effects of adrenaline on the smooth muscle receptors of the uterus. When it binds, it triggers a cascade that pumps calcium out of the muscle cells, preventing the actin and myosin fibers from locking together.
So it just freezes it.
It essentially freezes the uterus, completely stopping the contractions. This allows the spiral arteries to dilate wide open, blood floods back into the placenta, and the baby is revived. It buys the surgical team time to prep for a C-section if needed.
Okay, I'm going to throw a classic nursing student dilemma at you. Exams love prioritization questions. They always ask, what is the nurse's first priority action? In the real world, a team of nurses runs into the room and does all 4 of these things simultaneously.
Oh yeah, it's a team effort.
But on the NCLEX, you have to pick one. If my patient is having severe late decelerations, do I turn her? Do I stop the oxytocin? Do I hang the fluid? Or do I slap the oxygen mask on her face first?
It is the ultimate prioritization trap. When deciding what to do first, you must identify the root cause of the problem. You want to remove the primary stressor before you apply a physiological Band-Aid.
Okay, so oxygen is a Band-Aid, 4 fluids are a Band-Aid.
Exactly. The primary stressor is mechanical. It is either the heavy uterus crushing the vena cava or the powerful contractions crushing the spiral arteries. Therefore, your absolute first simultaneous priority actions are repositioning the mother to release the vena cava and stopping the oxytocin infusion to stop the uterine squeezing.
Remove the cause, then treat the symptom.
Remove the mechanical cause of the suffocation first. Turn her and turn off the pit. Then you slap the oxygen on and open the fluids.
That makes perfect logical sense.
Yeah.
Now let's pivot to a very specific, terrifying physical emergency, heavily emphasized in the text. The umbilical cord prolapse. We touched on this during the rupture of membrane section. The water breaks. The heavy rush of fluid sweeps the umbilical cord down past the baby's head and into the vaginal canal. The baby's bony skull descends and physically crushes the cord against the mother's rigid pelvic bone. Blood flow stops instantly.
This is not a slow decline. This is a dire, immediate life or death emergency. The moment that cord is crushed, you will see a profound, severe, prolonged bradycardia, or a massive variable deceleration on the fetal monitor that does not recover.
The nurse sees the drop. They quickly perform a sterile vaginal exam to figure out what is wrong, and their fingers feel a soft, pulsating, slippery tube sitting in the vaginal canal below the baby's head. What is the absolute priority action?
The absolute priority is physical, sustained mechanical action by the nurse. If you feel that pulsating cord, you do not remove your hand from the vagina.
You just stay there.
You push your fingers past the slick cord, you place your hand firmly against the baby's hard skull, and you physically, forcefully push the head upward, off the cord, back up toward the uterus, and you hold it there with all your strength.
You just hold the baby's head up. For how long?
Until the baby is delivered. You are now the only thing keeping blood flowing to that baby's brain.
But I need to tell the doctor. I need to call the charge nurse. I need to set up the OR.
This is a major exam trap. Do not ever, under any circumstances, leave a patient with a prolapsed cord to go get help. You use your other hand to hit the emergency call bell on the wall. You yell at the top of your lungs for someone in the hallway to notify the provider and prep the OR.
So you literally don't move.
But you do not take your internal hand out. You will literally climb onto the bed, ride on the mattress with the patient, keeping your hand inside the vagina, pushing the head up as they quickly roll the bed down the hall and right into the operating room. You stay there while they drape the patient, and you only remove your hand when the surgeon physically pulls the baby out from above through the abdominal incision.
That is an incredible visual of nursing responsibility.
Yeah.
While you are holding the head up, the other nurses in the room are positioning the patient to help you. What position is best for a prolapsed cord?
You need to enlist gravity to help pull the heavy baby back up into the abdomen, away from the pelvic choke point. You immediately drop the head of the bed and put the patient in a steep Trendelenburg position, head way down, feet way up in the air.
What if the bed is broken or won't tilt?
Then you instruct the patient to immediately flip over onto their hands and knees with their chest resting flat on the mattress and their pelvis high in the air. This is called the knee chest posture. Gravity pulls the fetus out of the pelvis, relieving the fatal pressure on the cord.
There is one more highly specific intervention the text mentions for cord compression. Let's say the water has broken, but the fluid is just a really low oligohydramnios. The cord hasn't prolapsed, but it's getting squished with every single contraction because there is no water to cushion it, causing severe recurrent variable decelerations.
In that specific scenario, the provider might order an amnio infusion. The nurse assists in placing an intrauterine pressure catheter, the IUPC we talked about earlier. But instead of just measuring pressure, they hook a bag of warm, sterile, normal saline to the tubing and literally pump fluid backward into the uterine cavity.
You are artificially refilling the swimming pool.
Exactly. You are replacing the lost amniotic fluid to create a hydrostatic cushion, giving the umbilical cord room to float freely without getting crushed by the fetal body parts during a contraction.
Let's give our final 5 takeaways for the emergency section.
Number 1. First action for fetal distress is usually repositioning to the side. Number 2, always stop oxytocin or uterotonics if there are late decelerations or tachysystole.
Number 3, tocolytics like terbutaline are used to relax the uterus if it won't stop contracting.
Number 4, for a prolapsed cord, manually elevate the fetal head and never let go. And number 5, amnioinfusion can be used for recurrent variable decelerations to float the cord.
Incredible. The mechanics of labor and the interventions required to manage it are so deeply intertwined. Which brings us to our conclusion. We have covered an immense amount of clinical ground today. We started with the foundational mechanics: passenger, passage, powers, position, psyche.
The 5 Ps.
We unpacked the anatomy of the fetal skull and the maternal pelvis. We learned why cervical transformation is the only objective proof of true labor. We assessed the cervix and fluid, understanding the critical nature of ischial station, the dangers of meconium aspiration, and the immunology behind GBS sepsis.
We really went deep.
We learned how to read the physical engine of labor through Leopold maneuvers and contraction hemodynamics, distinguishing between external TOCO timers and internal IUPC pressure sensors. We broke down the holy grail of fetal heart rate monitoring, dissecting the autonomic nervous system's control over variability, and matching the physiology of decelerations using veal entropy.
And finally, we learned the exact pharmacological and mechanical mechanisms to act decisively during intrauterine resuscitation and cord prolapse emergencies.
And if there is one overarching grand unifying theme to synthesize this entire complex journey, it is hemodynamics.
Blood flow.
Always. Every single physical assessment, every squiggly line on a monitor strip, and every emergency intervention in obstetric nursing is ultimately about one simple critical goal.
Yep.
Ensuring the maternal blood pressure is high enough to reach the placenta, and ensuring the placenta and umbilical cord are clear enough to deliver that oxygen to the fetal brain.
Supine hypotension cuts off blood. Tachysystole cuts off blood. Cord compression cuts off blood. Your primary job as a clinical nurse is to understand the plumbing and maintain that flow.
And as we wrap up, I want to ask you for a final provocative thought, something for our listener. The future nurse mull over as they close their textbooks, head into their exams, or walk onto the unit for their next clinical shift. We spent this entire time talking about how to read electronic monitors, track contractions, and react to jagged lines on graph paper. What is the danger in relying too heavily on the machine?
That is the perfect question to ground us at the end. Because in modern obstetrics, we focus so intensely on the electronic fetal monitor. We memorize the categories, we analyze the moderate variability, we obsess over the exact symmetrical shape of a deceleration. But you must always remember, the monitor is just a piece of paper. It is just a shadow on the wall reflecting a much more complex biological reality. The true clinical picture is the living, breathing human being lying in the bed.
The patient.
Exactly. If you ever find yourself in a situation where you have to choose between treating the monitor and treating the patient, look at your patient. How is her breathing? Is she shivering? What is her subjective pain telling you? Is her psyche terrified, or is she calm and coping? The best, most elite OB nurses in the world don't just read strips, they read people. The monitor simply tells you the what. Your clinical judgment looking directly at the patient tells you the why and the how.
Treating the patient, not the monitor.
Yeah.
It brings us right back to where we started with the X-ray analogy. The human body isn't a simple machine, and labor isn't a clean binary picture. It's muddy, it's dynamic, and it requires brilliant, adaptable, critically thinking nurses to guide two patients safely through it. To the listener, to the future nurse, understand the physiology, master the hemodynamics, trust your training, and approach your exams of your future patients with absolute confidence. You've got this.
You absolutely do.
Stay curious, stay sharp, and keep learning.